All right, let's reconvene. Our next panel is COVID-19 vaccine safety review. In this panel, our speakers will provide a review of data on COVID-19 vaccine safety and attitudes about it. I'm going to start it off in my role as NVAC chair as well as VAST co-chair. I'll be followed by Dr. Nicola Klein from Kaiser Permanente Vaccine Study Center, talking about surveillance for vaccine adverse events after COVID-19 mRNA vaccination. She'll be followed by Dr. John Beigel from the National Institutes of Health on booster safety research. And then we'll have Dr. Robert Kaplan from Stanford University providing survey findings on COVID-19 vaccine safety and acceptance. So I'm presenting this on behalf of the work of our COVID-19 vaccine safety technical work group. This group has been charged with reviewing and evaluating as well as interpreting post-authorization and approval COVID-19 vaccine safety data. We're serving as a central hub for technical subject matter expertise from federal agencies, conducting our post-authorization and approval safety monitoring, advising on analyses, interpretation, and presenting vaccine safety data, and then providing updates on the COVID-19 vaccine work group and the entire ACIP on COVID-19 vaccine safety. We've been reviewing data from a number of our safety monitoring systems, including the Vaccine Adverse Events Reporting System, the Vaccine Safety Data Link, the FDA BEST system, the VA, the Indian Health Service, and the Department of Defense, as well as having presentations from a number of our international partners, including the Public Health Agency of Canada and the Global Advisory Committee on Vaccine Safety, and have also discussed a number of special evaluations, including myocarditis case follow-up studies, which our VAERS colleagues and CDC Vaccine Safety Office have been leading. From December of 2020 through February 11th, we had 55 independent meetings to review this safety data. We had 15 joint meetings with our COVID-19 vaccine work group and 16 ACIP meeting presentations with VAST assessments. I should say this is through June, not through February. So since our last meeting in February, there have been 2 ACIP meetings for which VAST has provided assessments. On April 20th, the primary focus of the ACIP meeting was considering COVID-19 vaccine second boosters for adults, and we presented an assessment on the safety of the COVID-19 vaccine boosters. On May 19th, the ACIP was considering the Pfizer-BioNTech booster doses for individuals aged 5 to 11, and our VAST assessment was on the safety of COVID-19 vaccine in children 5 to 11, as well as VAST assessment of mortality following COVID-19 vaccination. This is just a visual representation of some of the many systems that have provided information that we have used in our discussions. And I think it's an acknowledgement of all of the many partners throughout the federal government that have been involved in these safety discussions. So for the first review, our VAST reviews are listed out here by date, talking about booster vaccines or booster dose safety. The safety of the first mRNA COVID-19 booster, data from VSafe in patients aged 18 and older. We saw that injection site and systemic reactions reported less frequently following the booster than following the primary dose and the second dose. For ages 12 to 17, the frequency of reactions were equal or slightly higher following the booster than following primary dose number 2. VAERS myocarditis rates were highest among males aged 12 to 29 years, and rates were higher than background, but lower than after the primary second dose. Pericarditis reporting was similar by sex and age group with low case counts, which complicated estimation of rates. The Vaccine Safety Data Link, or the VSD rapid cycle analysis, showed the only safety signal was on myocarditis pericarditis in the 21 days after the first booster dose. The myocarditis pericarditis did differ by age group. In the age 12 to 39 group, mostly myocarditis pericarditis with onset within 7 days after vaccination. and the rate per million after the first booster dose was not higher than after the primary series dose 2. For those over 40, most of the reports were of pericarditis, and the onset was later, onset out to about 3 weeks after vaccination. The VA system rapid cycle analysis showed no safety signals observed for the messenger RNA booster dose in a 21-day window. There were some chart review of 15 confirmed cases, 15 of the 40 cases of myocarditis, pericarditis reports after the booster dose. 10 of these were pericarditis and 5 myocarditis, and 14 of the 15 were in persons over 40 years of age. So the VAST assessment on the COVID-19 first booster dose that was presented to inform second booster dose discussions, or that we provided assessments on booster dose safety at 4 ACIP meetings. The assessment included data from VSD as well as VSafe, VAERS, and the VA. Reactogenicity following vaccination was similar to or lower than after the primary series dose 2. And further work and analyses are needed to understand the pericarditis risk. And while the data do not suggest safety concerns beyond those previously identified for the primary series, we're going to continue to monitor data on myocarditis and pericarditis following booster doses. Moving on to the VAST assessment of booster doses in those aged 5 to 11. We reviewed the most recent data from the U.S. safety monitoring systems, including safety after the primary vaccination series in those aged 5 to 11, safety after booster doses in those 12 to 15 years of age, and at that time, that was the youngest age group for which boosters were authorized. At the time of our review, there had been over 18 million doses of the Pfizer-BioNTech vaccine administered to children aged 5 to 11. In VAERS, the reporting rate for myocarditis among males was lower in age 5 to 11 as opposed to those aged 12 to 15. In the VSD rapid cycle analysis, there were no statistical safety signals after over 750,000 doses in those aged 5 to 11. And the data didn't suggest potential safety concerns regarding the Pfizer-BioNTech COVID-19 vaccine for booster doses in those aged 5 to 11 beyond the previously identified issues in older age groups. The VAST assessment regarding mortality following COVID-19 vaccination, this was presented at the May ACIP meeting. The CDC Immunization Safety Office and the FDA have standard and systematic methods for following up on all reported deaths following vaccination, and that's because of the importance of mortality as a potential adverse effect. VAST reviewed this mortality data as available from several different systems. And the population-based studies conducted to date have not identified increased risk of death following COVID-19 vaccination. The spontaneous reporting to VAERS has also not identified any unusual reporting or patterns of causes of death. In a cohort of 6.4 million COVID-19 vaccinees and 4.6 million demographically similar unvaccinated persons, there was no increased risk of mortality among those who received COVID-19 vaccination. Among over 20,000 nursing home residents in almost 300 facilities, there was no increase in 7-day mortality following COVID-19 vaccination. And among deaths reported to VAERS following COVID-19 vaccination, the Bayesian data mining identified no signals other than mortality due to COVID-19 disease or vaccine failure following the Johnson & Johnson Ad6 COVID-19 vaccine in adults. And there was no unusual clustering and causes of death associated with the U.S. authorized vaccines. So what are our VAST next steps? We're going to continue to review data from national safety monitoring systems and manufacturer post-marketing requirements. We're going to continue to look at real-time monitoring data on vaccine safety as we expand vaccination efforts to younger age groups, as booster doses continue to be delivered, and as new vaccines are authorized or approved. We'll collaborate across U.S. federal agencies evaluating vaccine safety, as well as with global vaccine safety colleagues on these key issues. And we'll continue to provide updates to our CDC colleagues, as well as to NVAC. And I want to acknowledge the hard work of all of our VAST members, our ex officio and liaison representatives. I particularly want to acknowledge Lori Markowitz and Melinda Wharton, who are the CDC co-leads, and I will then end my presentation and hand things off to Dr. Klein, who's at the Kaiser Permanente Vaccine Study Center. She's going to talk about surveillance for adverse events after COVID-19 vaccination. Dr. Klein, your slides are up. You have the floor.
Great, thank you. Thank you very much for the invitation. And that was really a nice introduction to what I'll be talking about today. I'll be, as Dr. Huskins mentioned, I'll be talking about monitoring COVID-19 vaccine safety in near real time within the Vaccine Safety Data Link. Next slide. These are my disclosures. Next slide. So the Vaccine Safety Data Link, as you've just heard, and some of you may be aware, it's a collaborative project between the CDC and 9 integrated healthcare organizations shown here on the map. It was established in 1990, and it includes healthcare organizations and members for over 12 million people in the United States. Today, I'm going to be talking a little bit more about kind of the structure of VSD and what VSD does and how we operate, and then use some examples about some of our COVID-19 studies in terms of how we utilized our existing infrastructure to do these studies. Next slide. So the VSD is what we call a distributed data model. And what that means is that all those sites I just showed you on that map, we all make our own data from our own electronic medical record systems, and we update it either annually or weekly. Most of these are for weekly updates, and we store all those data at each site. And then for each analysis in each study, we do a centralized sort of data pull from this, what you can see represented by this big computer in the middle. And then that data that's just necessary for the study is then transmitted back to the site that's leading the study. So that's what's called the distributed data model. So we're not sending all the data to a central area. All the sites keep their own data and just provide the data that's necessary for each study, including for these weekly RCA analyses. Next slide. So VSD has been conducting the rapid cycle analysis to monitor the safety of many vaccines for at least 15 years, perhaps more. And what it means is that we update the VSD data weekly, and we conduct analysis. And you can see the long list of previous vaccines of which we have done RCA studies for. I won't list them all, but you can see in red the COVID-19 vaccine, which is, of course, the topic of today's conversation. So in general, VSD rapid cycle analyses are best suited for outcomes that are clinically well-defined and coded in electronic medical record. They have an acute onset in that they happen only within a few days or weeks after vaccination. And typically we focus on serious outcomes, usually outcomes in the emergency room and inpatient setting, although not exclusively. Next slide. So talking about the RCA for the COVID-19 vaccine, the aims of this study were to monitor the safety of COVID-19 vaccines weekly using pre-specified outcomes of interest among VSD members, and then to also describe the uptake of vaccines over time amongst the VSD members. Now, we began surveillance in December 2020. Next slide. Now, I'd like to spend a minute talking about the outcomes. So these are the 23 serious outcomes that we monitor. And in terms of how to think about why we included these particular outcomes, you can really think of them in 4 groups. One is inclusion in prior vaccine safety study, and you can see a fairly long list: Guillain-Barré syndrome, anaphylaxis, et cetera, that we typically monitor for every new vaccine. There was hypothetical concerns regarding association of COVID-19 disease, and so that includes those outcomes listed here. And in addition, what isn't on this list, because it's in a separate section, is myocarditis, pericarditis, in which we were always monitoring for that outcome. But then during the course of the evaluation, that sort of got moved to the bucket of outcomes that were revised due to emerging concerns, and I'll talk about that in a minute. And you can see the other outcomes that we added due to emerging concerns in the lower left. And then finally on the right are we always include outcomes for which there's any hint of an imbalance in phase 3 clinical trials. In this case, you can see those 2 listed there. Next slide. Now, in addition, we also pre-specified that we were going to chart review these particular outcomes, as you can see checked, prior to doing the analysis, actually. So the analysis would include chart-reviewed outcomes. Myocarditis, pericarditis is a bit of an exception that was added. The chart review component was added a little bit later. Next slide. So just a word of how we actually do this. So what do we mean by when we chart review outcomes for an analysis? So on each week, we identify cases within the EMR during the appropriate interval. In this case, it's usually after 21 days after vaccination following COVID-19 vaccine. Next slide. We then perform actually what we call a quick review or quick chart review, and that usually takes place within 1 week. And that's to initially assess if a case is incident after COVID-19 vaccination. And if it appears to be a new onset incident case, we would include it in the weekly analysis as long as it meets other VSD case definitions. But if it appears to be a history of or not a new incident case or clearly is not a new case, we will exclude from future analysis. Next slide. Now, at that point, the cases that were included continue into full chart abstraction and adjudication after an appropriate time has passed, and that's usually maybe up to 30 days or something like that. Sometimes these patients are still in the hospital when we review their charts. We need to get their full medical records to finally make a final case adjudication. So what that means is on a weekly basis, RCA analysis included a week of quick review cases pending full chart review, and then also all cases confirmed after full chart abstraction and adjudication. And we did this system because it allowed the RCA weekly analysis to balance timely inclusion of preliminary chart confirmed data within also and fully reviewed cases. Next slide. So just spend a minute talking about the analytic plan for how we did our RCA analysis. Probably many of you have seen this before. We did comparisons between vaccinated-only individuals with what we call the vaccinated concurrent comparators. And what we did was, we take individuals who are vaccinated and during the risk interval, and that's 21 days after vaccination. And so on each calendar day that an outcome occurs in a vaccinee, in this case, for example, it's the myocarditis represented by the heart. For example, on June 3rd, we compared vaccinees who are in their risk interval with similar vaccinees who are in their comparison interval. So they're further away from their vaccine, but they're vaccinated. They're just in a comparison interval of 22 to 42 day intervals. And by similar, it means that they were in the same age group and at the same sex, race, and at the same VSD site. And so what that means is that all analysis are adjusted for sex, race, and VSD site and age. Next slide. So this is the preliminary, these are interim results that we published last fall for our initial RCA analysis. And I think these include the outcomes I showed you in the previous slide. And what I think the take-home message here is that we didn't find any signals for any outcomes, as you can see in the red box. This is after the primary mRNA series. And that included 11.8 million doses, roughly. Next slide. However, prior to this publication, we were doing work started over just about a year ago when I think everyone in this room is aware that there started hearing reports globally about mild myocarditis after COVID-19 mRNA vaccines. And so at that point, next slide, we started including only chart-confirmed cases of our cases of myocarditis in individuals 12 to 39 years of age. And so for our analysis, this is a graph showing what we found when we looked at the chart-confirmed cases, and you can see that clearly there's an elevated increase in the first 7 days after vaccination, and so statistically significant showed by in the box, but you can really see that with your eyes. There's really a spike in that first week after vaccination amongst these younger individuals. Next slide. And so when we did analysis, and this is 0 to 7 days after vaccination, you can see that rate ratio, unlike the prior slide where there are no signals, all the rate ratios, this rate ratio is quite elevated at 9.8, and this is again amongst 12 to 39-year-olds after the primary stage during 0 to 7 days after vaccination for confirmed myocarditis and pericarditis. Next slide. So we've continued to do monitoring, and now we've been doing it on the first booster doses for RCA. Next slide. So this is data that was presented in April, the ACIP. It's a little bit of a busy slide, but I think the take-home message really is when you look at after the booster dose of any mRNA vaccine following any mRNA vaccine, and that you can see that we did signal for myocarditis and pericarditis also with these booster doses in the individuals who are over the age of 12. Next slide. So just in terms of our preliminary analysis of that first booster dose, next slide. when we looked at a similar kind of timing after vaccination of symptom onset after the first dose. And this is preliminary 53 cases of myocarditis and pericarditis. And this is, again, in individuals just 12 to 39 years of age. But what you can really see is very much consistent with what I showed you earlier from the primary series. We are seeing a large clustering in that first week after vaccination, after the booster dose during days 0, in this case, it's 0 to 4, it looks like, in the younger individuals of confirmed myocarditis and pericarditis. Next slide. So we do a similar analysis. Again, this is a vaccinated concurrent comparators. We're only comparing vaccinated individuals to other vaccinated individuals who are further away from their dose. And in younger individuals, 12 to 39-year-old, after either vaccine, you can see an adjusted rate ratio of almost 4.9. So it's also elevated after the booster dose, and that's statistically significant, as you can see in that box. However, by comparison, we've also included the similar analysis in the same age group after the primary dose. And when you compare it up to the primary dose, we have a rate ratio of about 24 approximately. What we're seeing here is lower than that, but we are still seeing elevated rate after the booster dose. Next slide. So I think to summarize, the VSD COVID-19 vaccine safety monitoring, VSD surveillance is ongoing for all COVID-19 vaccines. VSD analyses are updated weekly. VSD is population-based and geographically diverse. Key VSD strengths are flexibility and access to good data. We have the ability to rapidly add new outcomes in response to emerging concerns. And we have access to comprehensive medical records and rapid case confirmation when appropriate. And then for persons aged 12 to 39 years, myocarditis, pericarditis risk was elevated after mRNA vaccination after both the primary series and the first booster dose, especially during days 0 to 7. But the rate per million first booster doses administered was not higher than after primary series dose 2 mRNA COVID-19 vaccination. Next slide. And this is just an acknowledgement of all the individuals who have worked hard and continue to do so for this project. Thank you.
Thank you, Dr. Klein. Our next presentation is from Dr. John Bigel from the National Institutes of Health on booster safety research.
Good morning. So thank you, Dr. Hopkins and the NVAC for inviting us to present. So we had conducted a study that I'll describe about the use of booster vaccines, and I was asked to present the safety data from that. So I wanted to give you the background on why we did this study. So in early 2021, when vaccines were coming out, it was clear that titers were decreasing. We would need a booster. And the question is going to be, at that time, was going to be when, if a booster is needed, when it's needed, what populations to boost. But then the last part of what do we boost with? And this idea that everybody got a vaccine, that if you got Pfizer, you got the Pfizer second dose. If you got Moderna, you got the Moderna second dose. But that was an unsustainable model, and we wanted to understand if we could use boosters, one vaccine to boost another vaccine. So that was the setup for us doing this study. And it was really designed as an immunogenicity study to say, what is the immunogenicity of one versus another? So this is the population. It was adults. Everybody had received an EUA-approved COVID-19 vaccine. It was at least 12 weeks after the last vaccine dose. That is early, but it was really the timing of when to get that population enrolled, to get data to inform for decisions that happened last fall. The study was designed to generate immunogenicity data to inform these public health decisions. It wasn't powered to compare between the groups to say one is superior to the other or even one is non-inferior, but it was really designed to be descriptive to compare the immunogenicity. So with that, we had 50 participants per group, and that group is defined as a primary vaccine and a booster combination. We had two age stratas, a younger group and an older group, and tried to balance those about 25 each. And we did have the ability with those numbers, with 50 participants, we had the ability to find common adverse events. So I show you the probability. I mean, if it's an adverse event of 10%, we can easily detect it with those numbers. If it's an adverse event of of 2%, we have less power. About 63% probability of finding those events. But when we're talking about rare events, it is we weren't powered at all. And again, this study wasn't designed for that purpose. The other thing I would point out is, again, the study was designed for immunogenicity, so there is no control group. There is no group that doesn't get a booster. It is everybody got a booster, and it was different combinations. So all we can tell is relative safety to each other, but we can't inform on the safety of the boost itself because we don't have a group that didn't receive that. So this was the setup of the 9 groups. We enrolled as the companies engaged and as we could get the companies on board. So the first that we worked with, because we had worked with them previously, was Moderna. So it was groups 1, 2, and 3 were people that had received the Janssen vaccine, the Moderna vaccine, the Pfizer vaccine, and then boosted with Moderna. That boost of note is at 100 because at that time that was the thought that was the 100 mics is the primary regimen, 50 ended up being the booster, but at the time we thought 100 was going to be the booster. The second group coming in was boosted with Janssen, the third group coming in with Pfizer. So it's basically a 3-by-3 table of the primary and the boost. So this is the demographics. We had 458 people enrolled, and essentially the very balanced demographics because of the sequential bringing on groups 1 through 3, and then 4 through 6, and then 7 through 9. That duration between the primary series and the boost is a little longer as that group went on. So that's highlighted at the bottom. Those 15.4 weeks for the first three groups, and then 18 and then 21. So that sort of reflected the different time frame that these groups were enrolled. So this is the immunogenicity. This was published in New England early this year, pre-printed last fall. And essentially, just to walk you through each slide, I'm going to turn because the print here is kind of small. So at the top is the binding antibody. At the bottom is the neutralizing antibody. The panel to the left is the Moderna boost. The panels to the middle are the Janssen boost, and the panels to the right are the Pfizer boost. Within each is the primary sequence that they got, and then within that, the days, 1, 15, 29. And I think what you will recognize is essentially that people come in and regardless of the vaccine that they get a good boost. There is the Janssen boost Janssen that is a little lower, and again with 50 participants, we weren't designed to do the statistics to say if that is significant or not. But every other combination, and you can just look visually, every other combination you get a good boost quickly and above the boost that they got with the primary sequence. So every combination is immunogenic, and that was the data that led to the recommendations that you could use any vaccine to boost any vaccine. So let's focus on safety, since that's the focus of this panel. So we collect safety several ways. We do solicited adverse events. The setup here is similar. On the left panel is the panel A is the mRNA with the mRNA booster with the Janssen at the top, Moderna in the middle, and Pfizer at the bottom. The middle panels are the Janssen boost. Again, Janssen boost Janssen at the top, Janssen boost Moderna in the middle, and Pfizer at the bottom. And panel C is the Pfizer boost. What I've highlighted or blocked in red is the homologous. So that's sort of the comparator group, if you will. And again, I think what you see is despite the systemic solicited events, the local solicited events, that they are remarkably similar across these three groups. There were, we also collected unsolicited adverse events. So we asked for a certain set of adverse events. We say, did you have this or not? And then we say, did you have anything else? So the unsolicited adverse events that were related to the boost were similar across the three groups, about 12 to 15% in any of them. Most were grade 1, grade 2. Most were 1 or 2 events, but again, the numbers are really small. We had 4 related grade 3 events, some more severe events. 1 vomiting, and somebody that was in a Moderna booster group, vomiting, fatigue, and insomnia, and 3 different people that were in the Janssen booster groups. We had 2 serious adverse events, those that lead to hospitalization or seeking medical care. There was an acute renal failure from rhabdomyolysis from a fall. It was judged unrelated. It happened 30 days after the vaccination. There was an acute cholecystitis that was 24 days after Janssen vaccination, again judged unrelated. We have pre-written study halting rules. There were no halting rules met. We assessed for new onset chronic medical conditions. There were no medical conditions that occurred, and there was adverse events of special interest, and it's a sort of a list specified by the FDA. There was severe vomiting that led to a medically attended visit, and somebody that had a Janssen boost. So just to wrap it up, I mean, the heterologous boost elicited similar or higher serologic responses as compared to the respective homologous booster responses. The one outlier is possibly the Janssen boost Janssen, but it was not designed to compare that. The heterologous boost and homologous boost had similar rates of solicited adverse events. And from our data, albeit smaller data sets, the totality of the safety data suggest that heterologous boost and homologous boost are not any different, but just reiterating that it was not designed to assess the rare and infrequent events. So this took a team across multiple study sites with some very dedicated operations labs, both in blue and green, to make this happen. And with that, I'll hand it to the next panel.
Thank you, Dr. Bajel. Our final presenter in this panel is Dr. Robert Kaplan from Stanford University. He's going to present survey findings on COVID-19 vaccine safety and acceptance. Dr. Kaplan, your slides are up. You have the floor.
Great. Thank you very much for having me. So I'm going to tell you a little bit about a series of surveys that we did in the year 2020. So going to the next slide. So the problem, I think you're all aware of, that a safe and effective vaccine holds great promise for resolving the COVID-19 pandemic, but a refusal to take the vaccines is going to diminish achieving herd immunity. Next slide. So in collaboration with HHS.gov, which is a national survey research organization, the Stanford Clinical Excellence Research Center conducted a series of national surveys, each involving about 1,000 participants. Starting in actually June of 2020, there were 3 waves of this. But the 2 waves that I'm going to focus on today were conducted in August of 2020 and replicated in December of 2020. Next slide. So part of what we are trying to get at is how human beings process information that comes in the form of multiple dimensions. And there are 2 different ways that cognitive scientists look at this. One is that people may average information that's given to them. So decisions are based on the weighted average of how people value individual dimensions. And each dimension is valued independently and mentally averaged. When click ahead, and in contrast to that, there's something that we call configural theory. And in this case, decisions are based on unique combinations of information. So for example, if you're a clinician, if you see a patient with a foot ulcer, that means something different if that's combined with high blood glucose. Next slide. So in a series of these experiments that we did through these national surveys, we varied 3 dimensions. So people were told about hypothetical vaccines. By the way, these studies were done before vaccines were actually first available. So that one condition or one aspect of the study varied hypothetical vaccine efficacy. It was, people were told that a vaccine was 30% effective, 70% effective, or 90% effective. We also varied descriptions of minor side effects. They were told that the probability of these were 50%, 70%, and 90%. And then we varied the probability of severe adverse reactions, 1 in 100,000, 1 in a million, and 1 in 100 million. And by the way, these were all pegged to information that we had about reactions to flu vaccines, because this, again, preceded the COVID vaccines. Next slide. So the question that we're focusing on today is this one. If this vaccine for the coronavirus was available without charge today, how likely would you be to take it? And going back as early as of May of 2020, we got numbers that looked something like this. So the likelihood that people said they were somewhat unlikely or very unlikely to take the vaccine actually exceeded the probability or the likelihood that people saying that they were very likely or somewhat likely to take the vaccine. And I think this is an interesting finding because it didn't change much over the course of 2020. So back, say, in September of 2020, before there was much sort of information and disinformation spread about vaccines, that people's estimated probability that they would take the vaccine was pretty similar to what it was after the vaccines were released. Next slide. So the experimental design then was a 3x3x3 factorial design. Again, the factors were protection against a COVID vaccine, minor side effects, and serious adverse reactions. And the outcome was the reported likelihood that people would take the vaccine. And part of what we were looking at is how people sort of absorb and process the information. So if they're evaluating these three dimensions independently, then when we plot the responses in these 2x2 plots, lines on the graph will be parallel. Where if it's a configural judgment, that is, people are looking at unique combinations of risks and benefits, then the lines will be non-parallel. Next slide. And this is just what people saw. And this is just an example. So they're told about vaccines for viral illness. They're told about vaccines having possible side effects and benefits. And they're told about what the likelihood or what these side effects might look like. So in the case of minor side effects, they were described as sore arm, low-grade fever, and headache. And for severe side effects, we use the example of encephalitis, meningitis, and Guillain-Barré syndrome. Next slide. So just to give you a sense of the representativeness of these samples, we use complex methodologies to assure that the study sample looks like the population of the United States. And this slide just shows that in both the August and the December studies that we're focusing on today, that the study population demographically looks almost identical to the U.S. population. Next slide. So when we look at people's estimated probability of taking the vaccine based on the probability of benefit, there was a clear, systematic linear relationship. By the way, that 1 on the scale of 1 to 4 meant the higher probability of taking the vaccine. So if the vaccine was described as 90% effective, more people said that they were likely to take it. Next slide. But this was not so for minor side effects. In fact, people were essentially unaffected by information about the probability of minor side effects like sore arm, headaches, or low-grade fever. Next slide. People were affected by the probability of serious adverse events, and we found this finding to be quite interesting because a lot of people feel that it's very difficult to differentiate these low probabilities. But what we found in these studies and replicated was that people actually were able to differentiate probabilities of 1 in 100,000 versus 1 in a million. There was not a significant difference between 1 in a million and 1 in 100 million. Next slide. So for those of you that follow analysis of variance models, there was a significant effect for chance of infection. That was the strongest effect. The effects for minor side effects were non-significant, and there was a small effect for serious adverse reaction. The interaction terms, that is combinations of these, were all non-significant, again suggesting that the way people process information is to simply average it. Next slide. Now, I just want to make one final comment. So we did find significant effects of information, particularly the description of efficacy. Again, we didn't find much effect of description of minor side effects and a little effect for description of major side effects. But when we look at the proportion of variance accounted for in people's estimated likelihood of taking the vaccine, other factors massively dominated over information about safety and efficacy. So, for example, if we look at the question, vaccines have harmful effects that are not being disclosed to the public, this is actually very strongly associated with political ideology. Next slide. And educational attainment is also a dominant factor. So again, looking at this question, vaccines have harmful side effects that are not being disclosed to the public. There's a very substantial difference between people who have less than a bachelor's degree and people who have a bachelor's degree or higher. And if, in fact, when you look at it across a wider range of levels of educational attainment, it's actually very systematically, linearly related. And go on to the final slide. So if you want to look at these papers, the paper that most of this information comes from, I did with Arnie Milstein. It was published in the Proceedings of the National Academy of Sciences in 2021. And we have another paper that's under review that contains some of the information that I presented today. So once again, thanks for having me, and I look forward to the questions.
Thank you very much. Are there any questions or comments from those in the room? John Dunn.
I thank you all for these presentations. These were very interesting. This question, it can go to any of you. It's probably most pertinent to Dr. Klein. I was wondering if you have any real sense or information, and I apologize if I missed it, about whether having adverse effects with any one dose of the vaccine tends to correlate with having it with subsequent doses. And sort of as a larger expansion on that, I'm really happy to see with the boosters that the incidence of side effects seems to be lower. And I wondered if that's truly that it's less likely, or if there's just a lot of attrition. That is, people who had a nasty reaction to their second primary dose maybe are less likely to want to get a booster in the first place. Or on the flip side, if truly getting an adverse effect seems to be a random dice roll for any given person with any single dose. I know there's a lot rolled up in that. Sorry.
Yeah. So it certainly is possible that individuals, in particular for the myocarditis outcome that we were looking at, that individuals who had myocarditis after the second dose, for example, wouldn't go on to get a next dose. So there certainly can be that attrition. I don't know how much it would impact overall the analysis, just because there's such a large population that individuals here and there, they make those choices, but it's not clear how much they would overall impact the overall results. We have not. I didn't have time to go into this, but most of our booster doses are amongst individuals who had the same type of vaccine. And so we don't have a lot of mixing and matching that we talked about. I mean, there's sort of less than 10% who got a different type of vaccine overall from their primary series. But we don't have a lot of evidence that we're seeing any increased risk, but we don't look to see if someone had an outcome, whether they had the outcome in the prior after the primary series, for example, the same outcome or a different outcome. But that's actually a really interesting question, and I think that there's lots of areas to investigate in the future. But yeah, we haven't seen any real evidence yet of that so far.
Great, thank you very much.
I can give an anecdotal response on that. A lot of it really ties into multiple different factors. I've had people that have had fairly significant adverse events following booster doses that have said, next time boosters around, I still want to jump right in and get it. I've had others that have said, even though I just had a sore arm and felt a little achy, I'm never going to get another, so I think there are lots of different factors, and probably at least a significant component comes down to how we ask the question and how we address the concerns. Again, another one of those issues we need to systematically assess.
Yeah, that makes a lot of sense. Thanks.
Chris Harrisman?
Yes, my question I think also goes to Dr. Klein, but maybe to all of you, but just the idea that, it's not surprising that we would see signals with the pericarditis and myocarditis. That was something that we've heard about all along, but I just wondered, as the data are presented, do you present information as well on the incidence of pericarditis and myocarditis following COVID infection? I just think that's important as we're looking at these adverse events to make a comparison between what we see with natural infection versus with vaccination or boosters. So just interested in that. Thank you.
Sure, I can certainly comment on that. I agree; it's a very important question and something that I think has come up in the past. We have talked sort of generally in the VSD about potentially setting up new studies to take a look at those questions, but it's actually quite complicated, and we are not set up to do that. Our studies are based on vaccinated individuals, and so we're not set up to monitor after disease for myocarditis. So, although I think that's a topic area for future endeavors, it's going to be a bit of it'll be a bit of an undertaking, honestly, to do well, given all the changes and the surges in the diseases and the vaccinations and what have you that's happened today. But yes, it is an important question.
Yeah, I would just comment that that's been a very open point of discussion in our discussions in the VAST committee, and obviously across our scientific communities. We recognize that at least our data to this point is that myocarditis following vaccination appears to be a bit of a different animal than myocarditis following COVID infection. Doesn't appear to be as severe. The data we've seen to date indicates that those that have myocarditis or pericarditis following vaccination tends to be fairly short-lived as far as the symptoms, and likely long-term outcomes are good. But we do need more investigation and more data going forward. Yeah. Jewel Mullen.
Thank you for the presentations. I'm trying to think through public behavior when it comes to knowledge of side effects versus symptomatic experience of those side effects, and whether or not over time we need to worry about how people decide about boosters, new vaccinations, particularly if they hear that COVID infections among people who have already been vaccinated might only produce some mild symptoms, and how we need to be thinking about otherwise preparing people to hopefully embrace and accept vaccines, but also be maybe more specific or explicit about the safety of some symptoms. I hope that makes some sense, but I hear people, and this is also anecdotal, weighing whether or not they want to go ahead and have some mild symptoms and be inconvenienced by a booster, as opposed to just saying, well, maybe I'll just have a mild case of COVID this time.
And then you throw the additional complication into that question of, what is your risk for developing ongoing symptoms, beyond that COVID infection? Is that modified by prior vaccination behavior? All of those are very important questions on the communication side, on the data side, and on the safety assessment side.
Right. And so then I'll raise you another and go back to in all seriousness, though, go back to yesterday's conversations around precision or personalized vaccination and how to be able to quantify what somebody might experience once they're vaccinated. So,
it comes back to what I think many of us have heard many times over the years. We've come a long way, but we've got an awfully long way to go in answering questions around COVID-19 disease and vaccination impacts and other things related to COVID-19 infection. Other questions or comments in the room? Bob Schechter online, raise your question, please, sir.
Robert, we see that you're unmuted, but we don't hear you. We also have Jeff.
Why don't we go ahead and have Jeff Dushin ask his question, then we'll come back to Bob Schechter. Sounds like we're having some microphone issues.
Thank you for all these presentations. They've been fantastic. My question is around the survey data, and I'm just wondering if you have data or plan to get data on what, if anything, would cause people to reconsider their reluctance to be vaccinated. Are certain features more important than others in changing someone's current intention?
Well, what we do know is that people are affected by information about efficacy, perhaps even a little bit more than safety. But I think the most interesting finding, at least to me, is relevant to the last question that was asked, and that is, how does new information affect the likelihood that people will take the vaccine? And again, if we go back relatively early into 2020, and so again, we did the first survey in May of 2020 before there was even any phase 1 data on vaccines, and then we had a survey in September of 2020, and then one in December of 2020. And what's interesting about those is that people's expressed likelihood of taking the vaccine didn't change very much. And it addresses this question of, well, how much did various information campaigns, including disinformation campaigns, impact the likelihood of people taking vaccines? And it appears not very much, that people were fairly locked into their expressed probability of taking vaccines, and that as time went on, again, if you look at that difference between September of 2020 and December of 2020, so in September, we really didn't know if the vaccine trials were going to be successful. But by December, by the time the survey was done, actually both the Pfizer and the Moderna groups had reported out the results, and the results were much more impressive than I think anybody expected. Yet the expressed likelihood of taking the vaccines didn't change. And we just found that fascinating. And as we followed this forward with other people's surveys as well, the people who are resistant to taking the vaccines as a percentage has changed, but it hasn't changed very much.
We come back to Bob Schechter.
We are still unable to hear you. If you are on your phone, try *6. If you would like to type your question in chat, we can communicate that to the room here.
There are other questions or comments online while we're trying to get Bob Schechter's question.
No one else at the moment.
Any other questions or comments in the room?
He's typing.
Okay, we'll give him just a moment. Technology.
This question is for Dr. Kaplan. Any insights into initial and persistent disinterest extending from the time before availability of risk-benefit perception?
Could you repeat that?
Any insights into initial and persistent disinterest extending from time before availability regarding risk-benefit perception?
Again, we just didn't see the change that we expected to see. And we find that part particularly interesting. We didn't ask questions about risk-benefit perception. I wish we would have. But we did ask a lot of questions about people's suspicion about government and their suspicion about vaccines being rushed to emergency use authorization and so forth. And those were persistently high. Again, these are not panels. They're independent cross-sectional studies over the course of time. But I think people became a little bit less suspicious over the course of time, but again, not very much. And that the dominant factors were not information about the safety and efficacy of vaccines. They were more closely tied to political ideology and to education.
If we have time for an additional question, again from Dr. Schechter. Dr. Beigel, any data on AEs from 50 microgram Moderna mix match boost to compare to the 100 microgram data?
So, yes, good question. So we actually we completed the 50 mic data several months later, and that data is just coming out and hasn't been published. There, again, it was with 50 people in each arm, and the adverse events in that looked very similar to the 100 mics. The difference, though, is if you remember when I was presenting the different cohorts, the interval at the bottom changed, the interval between the EUA and the boost, and that was even more so with the Moderna 50. It was a much longer interval. So we actually saw better immunogenicity, which is probably related more to B cell maturation and that interval rather than being at 14 weeks. This was at 20-something weeks. So it is probably more related to that, but the safety profile did not change.
All right, well, I want to thank the members of this panel. Thank you all for your presentations. Thank you for your questions. We will now move to our next presentation, Monkeypox 2022 U.S. Situation Summary. Our presenter will be Dr. Brett Peterson from CDC. Dr. Peterson, your slides are up. You have the floor.
Very good. Thank you very much. My name is Brett Peterson. I am the Deputy Chief of CDC's Poxvirus and Rabies Branch. I'm currently serving as the team lead for our clinical team for the monkeypox response here at CDC. Thank you for the opportunity to give this update. Next slide, please. So monkeypox is caused by the monkeypox virus. This is within the orthopoxvirus genus, which also contains smallpox virus, cowpox virus, and vaccinia virus, which is the smallpox vaccine virus. Monkeypox presents clinically as a disseminated vesicular or pustular rash that's often associated with fever, lymphadenopathy, and malaise. The disease is endemic in certain parts of Africa where the animal reservoir is believed to please small rodents such as roach squirrels, Gambian routes, and dormice. Next slide, please. Traditionally, the transmission of monkeypox virus is thought to occur through zoonotic contacts with infected animals. However, human-human transmission does occur most commonly through direct contact with body fluids or lesions of someone who has monkeypox, or with direct contact with materials that have touched the body fluids or lesions, such as clothing or linens. Transmission through respiratory secretions can occur when people have close face-to-face contact. Other possible modes of transmission, such as through semen or vaginal secretions, are currently under investigation. Next slide. In terms of the current outbreak in the United States, these data are already out of date, and we have a total of 84 cases in the United States spread throughout 19 jurisdictions. In terms of proportions, California, Illinois, and New York are still the most affected states to date. Next slide. Internationally, at this point, more than 2,000 cases have been reported worldwide in a total of 36 countries. The most affected countries to date have been the UK, Spain, Germany, Portugal, and Canada. Next slide. Fortunately, a lot of research has been done to develop medical countermeasures for smallpox, which can also be used for other orthopox viruses, including monkeypox. The current vaccines that are being utilized are Jynneos and ACAM2000, and with respect to treatment, we also have several medical countermeasures available, including tecovirimat, vaccinia immune globulin intravenous, and cidofovir. Next slide, please. Jynneos is a live vaccinia virus vaccine produced from the modified Vaccinia onca Bavarian Nordic strain. It's an attenuated, non-replicating orthopox virus, and it's also known as Imvamune, Imvanex, or MVA. Jynneos was licensed by the FDA in September of 2019 with an indication for prevention of smallpox and monkeypox disease in adults 18 years of age and older. CDC is also currently developing an expanded access investigational new drug protocol to allow the use of Jynneos in pediatric populations. Next slide. The other vaccine available is ACAM2000, which is also a live vaccinia virus vaccine, which is also a replicating vaccine. ACAM2000 was licensed by FDA in August 2007 and replaced the previous vaccine Dryvax. ACAM2000 is indicated for active immunization against smallpox disease only for persons determined to be at high risk for smallpox infection. CDC does hold an emergency access investigational new drug protocol, which allows the use of ACAM2000 for non-variola orthopox virus infections, including monkeypox during an outbreak. Next slide. Now, there are significant differences between ACAM2000 and Jynneos. The first, as I pointed out, is the virus used in ACAM2000 is a replication-competent vaccinia virus, whereas Jynneos is replication-deficient. As a consequence, with ACAM2000, you do see what's called a take, or a vaccine site lesion, that occurs infectious virus, which can be transmitted to other parts of the body or other people through inadvertent inoculation or auto-inoculation. In contrast, Jynneos, as a replication-deficient virus, does not produce a take or this vaccine site lesion. Similarly, with respect to serious adverse events, ACAM2000 does have risks for adverse events associated with uncontrolled replication of the virus, for example, progressive vaccinia or eczema vaccinatum, which are not expected to occur with Jynneos, and fewer expected adverse events are anticipated with Jynneos. With regard to cardiac adverse events, myopericarditis has been reported in association with ACAM2000 and is estimated to occur at a rate of 5.7 per 1,000 primary vaccinees. With Jynneos, the risk of cardiac adverse events is expected to be lower based on clinical trial data, which has not identified any instances of myopericarditis associated with Jynneos to date. With respect to effectiveness, ACAM2000 was assessed by comparing the immunologic response and take rates to the previously licensed vaccine Trivax, and similarly, Jynneos was licensed by FDA using comparisons of the immunologic response to ACAM2000 in addition to animal studies. ACAM2000 is administered percutaneously by multiple puncture technique in a single dose, and Jynneos is administered subcutaneously in 2 doses, 28 days apart. Next slide. Vaccines are being used for both pre-exposure and post-exposure prophylaxis. With respect to pre-exposure prophylaxis, ACIP did vote to recommend vaccination for select persons at risk for populations. Next slide. According to the ACIP recommendations, the people who should get pre-exposure prophylaxis include clinical laboratory personnel who perform diagnostic testing for orthopox viruses, as well as research laboratory workers who directly handle cultures or animals contaminated or infected with these viruses. ACIP also allows for certain healthcare and public health response team members designated by public health authorities to be vaccinated for preparedness purposes. Next slide. At this time, CDC does not believe that most clinicians in the United States and laboratorians not performing the diagnostic testing are advised to receive orthopox virus PrEP. We've not seen nosocomial transmission occur in this current outbreak in the United States or abroad. So we recommend that laboratorians consult with their laboratory biosafety officers and supervisors to identify risks and precautions, depending on the type of work that they are doing. And similarly, with clinicians and laboratorians using the recommended infection control practices and utilizing the appropriate PPE. Next slide, please. With respect to pre-exposure prophylaxis, the ACIP does have a number of contraindications for ACAM2000 among primary vaccinees, revaccinees, as well as household contacts, reflective of its properties as a replication-competent virus vaccine. Jynneos, in contrast, only holds a contraindication for serious vaccine component allergies, given the decreased risk or absent risk of uncontrolled replication as a replication-deficient virus vaccine. Next slide, please. With respect to post-exposure prophylaxis, I would first note that transmission of monkeypox does require prolonged close interaction with a symptomatic individual, and brief interactions and those conducted using appropriate PPE in accordance with standard precautions are not believed to be high risk and generally do not warrant post-exposure prophylaxis. Next slide, please. However, CDC has developed a risk assessment table to assist as a tool in providing guidance for when post-exposure prophylaxis might be indicated. It separates out exposures by their degree of exposure. As indicated here, a high degree of exposure might include unprotected contact between a person's skin or mucous membranes and the skin, lesions, or body fluids from a patient. In these high-risk exposures, PEP would be recommended. Next slide. For intermediate exposures, for example, being within 6 feet for 3 hours or more of an unmasked patient without wearing a surgical mask at a minimum, PEP could be recommended based on informed clinical decision-making after performing a thorough risk assessment to determine whether the benefits of PEP might outweigh the risks. Next slide. For low, uncertain, or no-risk scenarios, post-exposure prophylaxis is not recommended. Next slide. Next slide, please. So I just wanted to touch briefly also on the treatment considerations for monkeypox. What we've seen to date is that many individuals infected with monkeypox virus do have a mild self-limiting disease course, even in the absence of specific therapy. And the prognosis for monkeypox depends on multiple factors, such as previous vaccination status, initial health status, and concurrent illnesses or comorbidities. Next slide. CDC has provided some treatment considerations for monkeypox in terms of who might be considered for treatment following consultation with public health authorities and CDC. Those individuals might be persons who do have severe disease, for example, hemorrhagic disease, confluent lesions, or other serious sequelae. Persons who may be at high risk of severe disease should also be considered for treatment. Those could include individuals with immunocompromising conditions, pediatric populations, pregnant or breastfeeding women, people with a history or presence of atopic dermatitis or other exfoliative skin conditions, or persons with one or more complications from monkeypox. Lastly, persons who have aberrant infections with monkeypox virus in areas of the body that may constitute a special hazard, such as the eyes, mouth, or other anatomical areas, can also be considered for treatment. Next slide. In terms of options for treatment, tecovirimat is an antiviral medication that is approved by the FDA for the treatment of human smallpox disease in adults and pediatric patients weighing at least, that should be 3 kilograms. Tecovirimat is also known as TPOXX or ST-246. It is available as an oral and IV formulation and was approved by FDA in July of 2018 and May 2022, respectively. Tecovirimat is indicated for the treatment of human smallpox disease in adults and pediatric patients weighing at least 3 kilograms, and CDC does hold an emergency access investigational new drug protocol to allow the use of tecovirimat for non-variant orthopox viruses, including monkeypox. Tecovirimat is currently available from the Strategic National Stockpile as an oral capsule formulation as well as the IV formulation. Next slide. Vaccinia immunoglobulin is a product licensed by the FDA for the treatment of complications due to vaccination, so including progressive vaccinia, eczema vaccinatum, and several others. CDC does hold an emergency access investigational new drug protocol, which also allows the use of VIG for non-variant orthopox virus infections, including monkeypox. Next slide. Lastly, cidofovir is also available in the Strategic National Stockpile. Cidofovir is also known as Vistide. It's an antiviral medication approved by FDA for treatment of CMV retinitis in patients with AIDS, but CDC does also hold an emergency access IND protocol to allow the use of cidofovir for non-variant orthopox virus infections, including monkeypox. Next slide, please. Medical countermeasure requests for monkeypox can be made to the CDC Emergency Operations Center. The number is here. A request for vaccines for post-exposure prophylaxis or any of the treatment options, tecovirimat, VIG, or cidofovir, we're requesting come from state or territorial health authorities. These products will be supplied by the Strategic National Stockpile. And with respect to vaccine for PrEP, the CDC Drug Service does carry these vaccines and can be supplied by them. Lastly, CDC is available for consultations to assist with medical countermeasure utilization, including appropriate vaccine and antiviral use. And we have stood up a clinical consultation service to address these questions from public health authorities and clinicians. Next slide. So with that, I will stop, but I'm happy to take any questions you may have.
Thank you, Dr. Peterson. Are there any questions or comments from the members in the room? We have one question online.
Hi, can you hear me?
You're loud and clear. Go ahead, Daniel.
Hi, thanks. Very nice presentation, Dr. Peterson. I'm just wondering, in relationship to post-exposure prophylaxis, has Jynneos been studied in terms of either preventing secondary infections with smallpox or with monkeypox, either in humans, old data, or in animals such as non-human primates?
Yeah, thank you for that question. So our experience with Jynneos is very limited with either pre-exposure prophylaxis or post-exposure prophylaxis for the prevention of monkeypox. We do have data from historical studies during the smallpox eradication era suggesting that the traditional replicating smallpox vaccines did provide an estimated 85% protection against monkeypox. And what we know about the orthopox viruses is that they do induce cross-reactivity across the genus. So it is our expectation that smallpox vaccines can be used for monkeypox. In terms of actual usage and clinical studies of the vaccine, clearly licensure was based on non-inferiority studies comparing immunogenicity to the previously licensed vaccines. And we are developing more experience using Jynneos specifically in humans for prevention of monkeypox. CDC has performed a clinical study in the Democratic Republic of Congo where monkeypox is endemic, evaluating its use for the prevention of monkeypox in healthcare workers in these endemic settings. That analysis of that data in terms of effectiveness is still ongoing, but what I can tell you is that among 1,600 clinical study participants, no monkeypox disease was reported in any study participants during a 2-year monitoring period following vaccination, although one individual was identified through routine surveillance shortly after completing the 2-year monitoring period and was diagnosed with monkeypox. So as I said, effectiveness evaluations are still ongoing. The other sources of information we can point to is the historic experience using the replicating smallpox vaccines to successfully eradicate smallpox. That's different potentially from the non-replicating vaccines like Jynneos, but there is historic precedent for using these vaccines as a post-exposure prophylaxis intervention. Currently, we're very closely monitoring the epidemiology and the individuals receiving vaccine to date to try to identify how effective vaccine and how much benefit is being provided under its current usage as post-exposure prophylaxis during this outbreak. And there are considerations for doing clinical studies as well in this outbreak, given some of the uncertainties about how much benefit we may be providing, how effective the vaccine may be in the ways that we're using it. So hopefully that helps answer some of your questions.
Thank you.
The next question is from John Douglas online.
Yeah, thanks for that really good presentation. I had 2 questions. One is actually about post-exposure prophylaxis, realizing we're still learning about it. What's the time frame at this point that we think it's plausible to use it other than as soon as possible for a high-risk exposure?
Sure. So, given our limited data, there's not a very clear time frame. What CDC has recommended is that, as you note, the most benefit is likely to occur if given as soon as possible. We believe that it may be effective in preventing disease if given within 4 days. There may be additional benefit if given within 14 days in terms of prevention or possibly amelioration of disease. But these are very rough estimates, I think, extrapolating from previous experience with the replicating vaccines and during the smallpox eradication era. So I think that's an area where additional research is needed to further define those timelines.
And then my other question is sort of the larger, if I'm correct, is this the largest monkeypox non-endemic country outbreak that's been seen? And whether it's the largest or just really big, what are the early hunches about how this is going to play out?
Yeah, so this is absolutely the largest outbreak of monkeypox we've seen outside of endemic areas. The only previous outbreak that I would note is in 2003 when monkeypox was brought to the United States through a shipment of exotic animals for the pet trade, and it was transmitted to prairie dogs who then did infect individuals, and approximately 47 cases occurred in that previous outbreak. Otherwise, there's been some sporadic cases to the United States. There was 2 last year associated with travelers to Nigeria, where there has recently been a large outbreak and persistent endemic disease, and other countries. But in terms of a large outbreak like this, this is unprecedented outside of the endemic areas. In terms of where this is going, that's something that we're looking at very closely in terms of this new epidemiology that we're seeing and the apparent human-to-human transmission with longer chains of transmission than have been previously documented. So there is certainly concern here. And what we have seen in terms of epidemiology is that specifically populations of individuals who report men's having sex with men have been disproportionately affected. And, if it's entering these sexual networks, it's a little bit hard to predict, where this may end up. But we are still hopeful that there is the possibility to prevent further spread and prevent a situation where there's persistent transmission and resulting kind of endemic disease similar to other sexually transmitted infections.
Thank you very much.
Our next question is from Jill Mullen in the room.
Thank you for your presentation. Your last comments are a perfect setup to my question, which gets to so much of what we've been talking about, which relates to risk communication and helping people understand individual and population risk, how we communicate it, and then how we also communicate what people need to think about the use of limited resources such as vaccines and therapeutics, and to do all that in a way that also minimizes stigma. So I'm curious how you're working with communications and others at CDC and how we should all be thinking about that in our respective disciplines, given that your word unprecedented is something that, I think about, and we have many lessons that tell us we can't start soon enough in anticipating what else we need to be saying.
Yeah, so I appreciate those comments. Thank you for that. I think risk communication is essential, and given this new epidemiology and its potential parallels to other diseases like HIV, other potential sexually transmitted infections, we have pulled in our experts from HIV world, sexually transmitted infection world, to really help us hone those communication messages for these populations that may be at higher risk, while at the same time recognizing that there is this risk of stigmatization and avoiding that as best as we can. So we're relying on our experts there to really focus those messages so that they're appropriate and minimizing any potential risk of stigmatization.
And did I see Rob Schechter has a question online?
Due to his continued issues with his speaker, Dr. Schechter's question is, have the incubation periods varied from historical cases, and does that have implications for the window for PEP with Jynneos?
Yeah, so that's a very good question. And we just did recently release a health alert network communication describing more of what we're seeing clinically and epidemiologically in this current outbreak. And what we are seeing is that there is a bit different clinical presentation in that what we traditionally expect with monkeypox is the presence of a prodrome, including fever, fatigue, other flu-like symptoms preceding the rash illness. However, what we've seen in a number of cases in this outbreak is that lesion presentation can actually proceed before these prodromal symptoms, and the prodromal symptoms may not occur at all or be more mild. Similarly, with incubation periods, we are seeing what appear to be shorter incubation periods, and that may be related to the route of transmission and direct inoculation through this sexual contact that appears to be occurring. And so that may lead to a bit of the different clinical presentation that we're seeing and perhaps shortened incubation period. And there may be analogs there to what we see with smallpox vaccination with replicating viruses, where after the inoculation of vaccinia virus directly into the skin, we do see those vaccine site lesions appear within 3 to 5 days. And similar to what we're seeing with monkeypox, that can precede some of the prodromal symptoms as well. So that is one hypothesis for what's going on, and how that may impact the success of vaccination for post-exposure prophylaxis, I think remains to be seen.
Thank you very much, Dr. Peterson. We appreciate your presentation and answering the questions. At this time, we're going to move to our next panel. Our next panel is called A Paradigm Shift, Improving Representation in Clinical Trials. We have 2 presentations in this panel. First will be Dr. Carlos Del Rio from Emory University. He'll provide an overview of a report from the National Academies on improving representation in clinical trials. He'll be followed by Dr. Zeke McKinney from Health Partners, talking about community partnerships he's used to expand diversity in clinical trials. Dr. Del Rio, you have the floor. Your slides are up.
Thank you very much, Dr. Hopkins, and I really appreciate the opportunity to be here speaking to this committee. I will be presenting a report that I was a part of the committee. This is a report for the National Academy of Sciences, and it was commissioned by Congress and on looking at how do we improve representation in clinical trials and in research. So why does this matter? Why is this critically important? Well, because, it compromises generalizability. It costs billions of dollars. It hinders innovation. It really compounds low accrual that then causes trials to fail. There's lack of access to effective medical interventions to people that may need it. It undermines trust, and it really adds to compounding health disparities. And one thing that we learned as we were doing this is the data reporting practices are insufficient. Women now represent over 50% of clinical trial participants in the U.S., which is good. But pregnant and lactating people, sexual minority groups and racial and ethnic subgroups remain significantly underrepresented. And racial and ethnic diversity in clinical trials has largely been stagnant. If you look over the years, we really haven't made much of a change. So specifically addressing to your committee, I want to point this paper that I wrote together with some colleagues and recently published in JAMA Network Open, in which we looked at the inclusion in vaccine clinical trials. And this just addressed vaccine clinical trials, went back and looked at what we could gather from vaccine clinical trials. And in 230 US-based clinical trials with over 200,000 participants and trials that reported age and sex, only 58.3% of those trials reported race and 34% reported ethnicity. So even when you look at the data, it's really hard to really get the data that you actually need. And when you look at adult vaccine trials compared to the US Census, what you find is that white individuals are overrepresented. Black American Indians and Hispanic individuals are underrepresented, and actually females are overrepresented. And, we had a lot of discussions in the committee of why this happened, but it may be that a lot of vaccine studies are done through pediatricians' offices, and mothers may take the kids and then they volunteer for studies. So a lot of questions about why women were overrepresented, but they clearly are. So let me move on to the conclusions from our committee. Number one is that improving representation in clinical trials is urgent, but this will require investment. This is not going to happen automatically, and this is going to require really dealing with a lot of barriers, and a lot of those barriers will require investment to make it happen. We need to improve transparency and accountability, because there's still not the data that you need to really be tracking this the way you would like to track it. And it is really the responsibility of everyone involved. The clinical research landscape involves multiple stakeholders, their study participants, their communities, their investigators, their IRBs, their industry sponsor, institutions, funders, regulators, journals, you go on and on. And it was interesting, many of the stakeholders said, no, not my issue. That's not my issue. That's not my issue. This is somebody else's issue. But nobody really said, and I think it's very clear that all the different stakeholders have to take a stance on this. And, journals can say, if you don't show this representation, if you don't give us your tables, we will not publish it. You can do all sorts of things, but it was clearly that this is going to require everybody to be involved. I'll put the example of the sponsors. Many times, I think about the COVID vaccine studies and having been involved in many of those studies. There was a huge push to do this quickly. And when you talk about doing studies quickly, the easiest to reach populations are the ones you enroll. The harder to reach populations are going to take more time, but time is money in clinical research, and the faster you do it, the better it is. So I think, again, the investment is going to take us more time to do this, because it will, in order to reach the representation we need, we have to do this. And I'll give you the example of another study I was involved. HPTN-083 is a study of injectable cabotegravir for HIV prevention. And there, the protocol team and the decision was made from the study team that, your site was stopped. You had to stop enrollment. We made a decision that 50% of our participants needed to be African Americans here in the U.S. And if your site was only recruiting, white individuals, you were told we were holding your enrollment until you enroll an African American or two. And by doing that, they were able to push the enrollment to where you needed to be. So there's ways to do it. There's carrots and sticks ways of doing this. And there's going to be there'll have to be a sort of a paradigm shift. And this paradigm shift is really moving the balance of power from institutions and put the priorities and interest in the community. I think we really need to think about how do we do clinical research by involving more in clinical trials and vaccine trials and many other studies, more involvement of the community and having a voice in the studies. So the recommendations specifically are that the Department of Health and Human Services should establish an interdepartmental task force on research equity charged with coordinating data collection and developing better accrual tracking systems across federal agencies. The NIH should standardize the submission of demographic characteristics in trials, clinicaltrials.gov, beyond the existing guidelines, so the trial characteristics are labeled uniformly across databases, and they can be disaggregated, extrapolated, and analyzed by the public. So greater transparency. As far as accountability, we recommended that the Food and Drug Administration should require study sponsors to submit a detailed recruitment plan no later than at the time that investigational new drug or investigational new device applications are submitted, and explain how would they ensure that trial population appropriately reflects the demographic of the disease or condition under study. We recommend that the Office of Human Research Protection and the FDA should direct local institutional review boards to assess and report the representatives of clinical trials as one measure of sound research design, and as it relates to the protection of human subjects. As far as incentives, Congress should direct the FDA to enforce existing accountability measures, as well as establish a task force to study new incentives for new drug and devices for trials that achieve representative enrollment. And CMS should expedite coverage decisions for drugs and devices that have been approved based on clinical development programs that are representative to the populations most affected by that condition. And CMS should incentivize community providers to enroll and retain participants in clinical trials by reimbursing for the time and infrastructure time required to do this. As far as remuneration, we said that federal regulatory agencies, including OHRP, NIH, and FDA, should develop explicit guidance to direct local IRBs on equitable compensation to research participants and their caregivers. As far as education of workforce and partnerships, all entities involved in the conduct of clinical trials and clinical research should ensure a diverse and inclusive workforce, especially in leadership positions. Again, we emphasize that in many studies, a lot of the PIs continue to be, white and overrepresented also male. And how do we develop a workforce of underrepresented populations that will become the leaders in clinical trials? And HHS should substantially invest in community research infrastructure that will improve representation in clinical trials and clinical research. So I would encourage you to look at the report. It's available in the National Academy's website, and I'll be happy to answer any questions after the panel is over.
Thank you, Dr. Del Rio. Our next presenter is Dr. Zeke McKinney from Health Partners. Dr. McKinney, your slides are up. You have the floor.
Yes, hi. Thank you so much to HHS, NVAC, to Dr. Del Rio and everyone who's here, and thank you so much for having me. As stated, I am the program director of the Health Partners Occupational Environmental Medicine residency, as well as a faculty physician in that program. It's where I trained. I'm also an affiliate assistant professor for the University of Minnesota School of Public Health and a research investigator, as well as a research clinical informaticist for Health Partners Institute, as well as president locally of Twin Cities Medical Society. Let's go to the next slide, if you don't mind. So just to tell you a little bit about myself, I'm from here in Minneapolis, from North Minneapolis, primarily African-American area, and I am African-American. We saw here in Minneapolis, George Floyd's murder in May of 2020 really set off national conversations regarding systemic racism. This was overlaid with COVID-19, having greater incidence, death and transmission in communities of color, especially seeing, more essential workers in these communities. Next slide, please. So I just want to stop and talk about Juneteenth, which is this weekend, June 19th. These are some other names for Juneteenth, including Jubilee Day, but that's the flag for Juneteenth. Please, the next slide. So, if you go back thinking from that date, 1865, the Emancipation Proclamation was in September 1862. And then as of January 1863, slaves were supposed to be freed. Next slide, please. We ran into an issue, though, because Emancipation Proclamation only really was enforced where the Union troops were. And so slaves everywhere weren't immediately freed, and not necessarily did everybody even hear about this. And at that time, Texas was pretty rural and remote. And so it wasn't until June of 1865 when General Gordon Granger went basically to the last outpost of where slaves were in Texas and told everybody, you know what, in fact, you are free. And that was about 250,000 people. So Juneteenth is a big deal. It's considered sort of Black Independence Day. And so that's what you should celebrate this weekend. And that's why this conversation is really critically important as well, not just for the Black community, but other communities as well. Next slide, please. So ultimately, even after that happened, by the way, the slaveholders still even delayed telling the slaves about it until after they were done with the harvest that summer. So it was pretty significant. Next slide, please. So we saw COVID had inequities broadly across different racial and ethnic groups. These are chloropleth maps, or more broadly known as like heat maps. On the left, we're looking at incidence. On the right, we're looking at mortality, where A is white, B is Black, C is Latino, Latina, D is Asian, E is indigenous, and F is Native Hawaiian. And ultimately, I'm just trying to prove the point that you see higher incidence of COVID in Black and brown communities. Same thing as mortality on the right there. Next slide, please. Now, speaking to my expertise in occupational medicine, occupational health, I just think this is really important. Like with COVID, we saw, as with all diseases for which workplace environment is a root cause, the most marginalized workers with the least power and resources, that is, people who are undocumented, incarcerated, people of color, women, lesbian, gay, bisexual, transgender, or queer, are the least likely to have access to testing for disease and the most likely to be missed in cohort enumeration. Wait. So I have to stop there and ask myself, so you're telling me the people who are going to be the most at risk are the ones we don't have resources for, and we don't even know that they're having the problems? That's a big epidemiology issue and a big issue in public health that we need to continue to address. Next slide, please. So we know systemic racism broadly impacts clinicians and public health professionals. We know there tends to be implicit bias against communities of color as well as other underserved communities, specifically as it pertains to making our decisions in medicine and as we communicate with patients. I like this little diagram on the right just because it says, well, look, we know physicians or clinicians have some bias. That may lead to patients having distrust or dissatisfaction with the system, and then ultimately not engaged with healthcare or research in the way we want. And what's missing in that gap? Well, how we communicate with people. Now, I'm speaking to this from a clinical lens, but this applies equally well to research too. And while we try to address cultural sensitivity, cultural competence, often we fail to talk about the why and the how of this mistrust and this distrust, both from a research and a healthcare perspective. And I think a lot of this comes from these historical and contemporary peripheral traumas. We talk about, harms in research. People like to talk about Tuskegee, and I'll talk a little bit more about that in a minute. Law enforcement violence is a big deal with George Floyd, Dante Wright, et cetera. Me as a Black man in America, seeing George Floyd get murdered 1,000 times in a row on TV, that is a peripheral trauma to me. That does not help my well-being. Next slide, please. So this peripheral trauma is both historic and contemporary. So I mentioned Tuskegee briefly. Now, Tuskegee is an interesting case because it's just so famous. It went on for such a long time. It was so egregious where, the folks in this study did not get the accepted treatment of penicillin even for, 20 years after that it was available. I mentioned Marion Sims because people may not know as much about him. He's considered the father of modern OBGYN, developed some very elaborate surgical techniques, but he did it by experimenting on slaves, obviously without their consent. We know there's a lot of infectious disease stigmatization that happens across communities. AIDS was a big one in the 80s and 90s, but now with COVID-19, people were talking about the China virus, and this has led to a lot of Asian American hate here in the United States and probably elsewhere. In clinical medicine, we know that communities of color or poor people, or again, less people more affected by social determinants of health are less believed. They're called drug seeking, they're called malingering, they're called difficult patients. We shouldn't use that language. We should stop blaming the victim. That's a real thing. But socially, we know, again, all these other traumas exist, like, again, law enforcement violence, redlining, which is the practice of, not allowing communities of color to buy houses in certain areas. And that white box right there shows some of the text and the language of a redlining covenant. Cultural appropriation, I use the Redskins logo. Thank goodness they got rid of that now, but that's a very obvious one that has happened before. And then, of course, we know there's huge stigma around immigration and documentation status. Next slide, please. So to tell a story, back in June of 2020, I go into a new barber shop in my old neighborhood, North Minneapolis. I need to get my hair cut at the beginning of the pandemic. And I walk in and I'm the only person wearing a mask in there. And I almost freaked out and ran out of there. But I said, wait a second. If I really want to engage the community, I better be willing to, take a risk and sit here and talk to people. And to be honest, they were very suspicious of me when I started asking all these questions about COVID. I was actually a little worried they were going to get fined, because there was actually regulations that people had to wear masks. But, through going in there, people started to ask more questions. People started to be more interested in vaccines, and we got to have a lot of great conversations. So I wrote this article about it in our state medical journal. Next slide, please. But what followed after that was even more interesting, because then in September of 2020, I became one of the investigators on the local AstraZeneca vaccine trial here in Minnesota. And one of the big things that I felt was really important was having adequate representation in research. Now, I always kind of joke around and tell people, like, look, if we did this study in vaccines and only white people, communities of color would have great concern about that. Inversely, if we only did the study in Black people, people would be freaked out about that too. So what's the right answer? Well, we should try to reach parity with our population statistics and say, well, if the city, the Twin Cities area has 20 to 25% Black people, that should be the proportion of Black people in our study, and vice versa. And so I think we did a really good job of this, and a lot of this was through outreach that we did with media, such as the local newspaper Star Tribune. Next slide, please. But I then really was trying to be on the ground, both at the barber shop or this article on the left was in our local Black newspaper, the Minnesota Spokesman Reporter, where I wrote about how these trials are really safe and protect human rights. And I spoke a lot about Tuskegee in that article to explain, even though Tuskegee was a huge research atrocity, what happened when the Associated Press reported on this in the 70s, it led to national outrage, and later in that decade to the development of the National Research Act and the establishment of the Belmont Principles and everything we know to be right in research, starting with research is voluntary. You can't coerce people. You have to allow people to get in and out of it, and also, understand the risks and benefits of being engaged in research. And so I tried to tell that story because we hear the bad stuff about Tuskegee, but we don't know the silver lining that came from it. And I'm not saying that I'm glad Tuskegee happened, but I'm glad that despite something terrible happening, something good came from it. Similarly, it's a terrible atrocity that George Floyd was murdered, but I hope we can continue to learn things about systemic racism and how this continues to be an issue that we need to address both in research medicine and more broadly in our society. And then on the right, you just saw this, there's a news story of me, and there was a bunch of times like this where I talked on the news and spoke about, here's why people, communities of color, white communities, everybody should get engaged in research because we want people to be adequately represented. Next slide, please. So ultimately, we have to try to provide people good information and combat the misinformation out there. And that starts by not making assumptions about who people are. Just because somebody looks a certain way doesn't mean they think a certain way. Research concerns, aren't the same for white people and aren't the same for Black people. They're all individual, though you will see some themes across them. But people have different knowledge, people have different lived experiences. And so you can't just look at somebody and say, oh, this is what somebody believes. You also have to actively listen. That's critically important as a clinician, but it's really important as a researcher too. And, we see more from the national academies talking about engagement with communities, community-based participatory research, providing research results back to participants so they can have engagement at that level. And that stuff is all ultimately very important. And we have to understand where, what do we want as researchers? How does that diverge from what the community may be asking for or seeking as well? And so that's why collaboration with local organizations to find out what they're comfortable with, what appropriate approaches are, is really important. And even though I didn't think CVPR, was going to be my area of expertise, the past couple of years has showed me this is something I'm good at, and that, of course, continues to be really needed. And so here I am talking about it. And ultimately, we have to make information accessible for folks. Next slide, please. So it starts by building or rebuilding trust. And that means, representing people at all levels of institutions, whether it's in the workplace, whether it's in academic medicine. We know Black physicians are rare, especially Black male physicians like this guy, but even more in academic medicine or research, we're super rare. I talk about this issue of restorative versus retributive justice. Very much in our society, we have all these retributive justice venues, whether it's criminal justice, you get punished in society and you go to jail, but then even if you've served your time, you get out and you're still punished again by not being able to get a job, not being able to get housing, and so on. Restorative justice, and whether, again, we're talking about criminal justice or in the workplace or in other settings, is really about having all parties understand the harms that have been caused and not actually specifically punishing people unless it's really trying to achieve an end. Now, arguably, you should save retributive justice for really bad things. Someone was murdered, somebody embezzled $1 million, but, if somebody's late 5 minutes to work, don't fire that person. Find out what the barriers are to them getting done what you want to get them done. And really, again, figure out how to engage people at their level, whether it's text messages, emails, conversations, phone calls, video. Do you need to put things in people's language? I'm very impressed at the number of ASL translators on this call today, and that's great. And ultimately, be transparent about what your concerns are, whether it's, again, from my perspective, occupational health or research, et cetera. Next slide, please. So one of the biggest barriers we hear people say about research is, I don't want to be a guinea pig. And so we have to reassure people that, again, like in clinical medicine or in research, patient autonomy is really critical, and you have to be able to choose for yourself. You are a volunteer. You can stop at any time. Whether, when we're talking about clinical medicine or research, we have to say, well, here's what we're offering you, and here's what the benefits are versus the risks. And, this has been reviewed by an IRB. Again, that goes back to the National Research Act. And so there are people overseeing this to make sure that we are not harming you unnecessarily or without some greater potential for benefit. And similarly, talking about the good side or the good outcomes of what came from Tuskegee, I think are really important. Next slide, please. So ultimately what we're shooting for, and this is everybody's favorite slide, is, in reality, we see this outcome of people trying to see this baseball game, and some people have a differential degree of resources. Equality is saying, well, give everybody the same degree of resources, regardless of what the outcome is. We know nowadays, new school equity is, well, give people the right resources so people can achieve the same outcome of looking over this fence. But the argument I've been making this whole time is, just get rid of the fence altogether. Get rid of the barriers so you don't have to worry about how do we bring people up to have what they need to achieve that same outcome. With that being said, I hope this has been informative about, how do you really do some boots on the ground, community-based work to increase engagement and representation and research. Thank you so much for having me today.
Thank you, Dr. McKinney. Are there any questions or comments from the members of the committee in the room? Now, I'll just raise one comment. We're in an interesting situation. In our clinical settings, many times we're trying to teach our learners and to focus our activities on not biasing our actions toward people's race or ethnicity. Trying to treat all that we see with equanimity, recognizing that we all have our biases. Yet at the same time, we need to make sure that we address in our clinical trials and our other activities where race and ethnicity is important, where representation is important, we involve those people in our trials, we involve them in our trial design. It's a challenge kind of reaching a good and safe footprint on both sides of those issues. Any comments from either of our presenters?
I'm in full agreement with you that we should treat everybody equal, but at the same time, we have to acknowledge that society and history and institutions do not treat everybody equally. And therefore, the ability of an individual, if I discharge a patient and give them a prescription for X drug and hope they're going to be able to fill the prescription and take the drug, and I don't take into consideration that some of them are insured and some of them are not insured, and some of them need additional resources in order to get that medication, the outcomes are not going to be the same. So that equity it does not lead to similar outcomes. And I think that's when what was presented here is we need to really focus on really creating equality, right, and really giving a way to acknowledge the enormous barriers that exist in people's ability to access and to do things. I will tell you, in many study participants that come from minority populations, frequently what you hear is, I would love to participate in the study, but the number of hours that I need to dedicate to come to the site and to do this and to do that will prevent me from going to work today, which means I'm not going to get paid, which means I may lose my job. And the compensation for that study participant is significantly, it doesn't even remotely cover the cost of one day of work. So what you end up seeing is a lot of people, and I think particularly in vaccine trials, having done research in both therapeutics and in vaccines, I've learned very early on that participants in vaccine trials are healthy volunteers. And many of them, for example, in HIV vaccine trials, are actually giving themselves time and effort because they're not getting anything out of it. So what you end up seeing is that people participate in those studies are primarily people that have the luxury of time and resources in order to participate. And they're not the people that necessarily need to be involved in the studies because they may not represent the most important population for you to access. And examples of that are, look at many HIV vaccine studies in which, phase 1, 90% of participants are white, yet that's not the population most impacted by HIV in our country, right? So how do we ensure that the people that we enroll into studies are actually representing the community most impacted? And that requires a very different approach. We can't treat all participants equally because we're not going to get those participants that actually are harder to reach.
Yeah, thank you, Dr. Del Rio. I have to agree with you that volunteer bias for those who have the luxury of participating or who have the luxury to take a day off if they have a side effect from a vaccine is a very real thing, and we continue to see that in research. To put what Dr. Del Rio said more succinctly, this is much like the argument when people talk about systemic racism and say, well, I'm colorblind, I don't see race. And that's a nonsense or a very ignorant thing to say, because that's disregarding the systemic factors, the social determinants that race has involving economics, education, everything else. And so again, it's not that we need to treat people differently, but rather appreciate how the system has treated people differently in terms of how we can engage people appropriately in research and understand the impacts that what we're doing may have on these folks. Or as Dr. Del Rio said, the fact that we want somebody to take a medication may be limited by the barriers that they have to getting that medication.
Building some of that motivational interviewing piece in to try to solve some of those problems early on. Any questions or comments from our members that are on the live stream? Jeff Dushin, I understand you have a question.
Thank you. And I really want to commend the NVAC leadership for bringing this discussion to the meeting. I think this issue of systemic racism in medicine and in research is critical for us to continue to keep front and center. And this has been a fantastic discussion today. Thank Dr. McKinney and wish you a happy Juneteenth. And have two questions. One related to the issue of leadership in medicine, in research, and bringing more people of color, into leadership positions, and some of the challenges and solutions that might be suggested in order for us to do that. I think that is one way to sort of achieve some of the goals that you have set out for us. And then for Carlos, thank you for your presentation. One thing I hadn't considered previously was the cost associated with the type of discrimination that you described. And I'm wondering if you can just say a few words about how those costs are incurred.
Thank you, Jeff. We had there were in our committee several health economists, including Dana Goldman and several others, and we talked about the cost of the cost of not having the participation of the adequate number of study participants. And I am not at all a health economist, so I'm probably going to be messing this up a lot. But what Dana and his group did as part of this report, and there's a white paper associated with it, is they really looked at, okay, if you don't enroll the right participants, then you're not going to be able to, there's going to be mistrust. You're not going to be able to expand the use of this medication, this device, this vaccine into those populations. There's not going to be the necessary acceptance. And that's going to lead to disease, which then has cost associated with it. And he and his team did the modeling, estimating what the cost would be. So his argument was that the lack of representation of clinical research actually has significant cost implications for our healthcare and our healthcare system, and that by addressing those issues initially, we would be better off, and it will lead to a decrease in the cost of care for many populations.
Thank you.
Yeah, and to answer your question about, how do we increase the pipeline, I'd say, towards leadership positions in medicine and research from communities of color. I mean, look, so, the data has shown that probably the number one predictor of success in the long term is actually pre-school education, pre-K education. And so having, universal access to that in the United States to all communities, and that also, of course, helps from a child care perspective for the parents, is a huge thing. But, even if you have a motivated student who does great in high school and gets a scholarship to college and does well and wants to go into medicine or go get a PhD, but let's just say medicine, the costs of getting into medicine are huge. The test prep courses you need to take the MCAT, the cost of taking the MCAT, the cost of applications in medical schools, the cost of going on interviews. I mean, I see students on Twitter talking about this all the time, and those are huge barriers. In my case, I was out of college 2 or 3 years before I applied to medical school, so I was able to save up a little bit of money. If I tried to do it straight out of college, which, by the way, it was hard enough to get through and finish paying tuition, that would have been a nightmare for me. And so, having more access to resources for students to get in and make it easier is great, because even though there may be scholarships out there to pay for some of these application costs and things like that, you're adding an extra layer of work on for people to get that, in addition to the work of actually trying to get a good application, a good personal statement, being prepared for a good interview. And that's notwithstanding even having opportunities to, shadow clinicians or be exposed to different areas of science or medicine that are of interest. So I think there are lots of layers to it, and it's obviously, of course, not a simple problem to solve. But thank you for your question.
Thank you.
Jeff, and the reality is that we've made very little change. I mean, in the last, 50 years, the number of Black physicians in our country, Black male physicians, has almost been flat, right at 2 to 3%. We talk a lot about increasing, racial representation in medicine, but we really have not gotten there. If you look at the NIH data, who gets, K awards, the number of minorities that get K awards has stayed flat over the last 20 years. So I think we have to stop just tracking the information and looking at the numbers and really implement the necessary strategies to create that equity that is necessary, because it's not whatever we've been doing to try to change this has not made a difference. And I think we have to acknowledge failure and think about different strategies.
Well, pardon my ignorance on this, but is there a roadmap comparable to what the national academies laid out, for example, with respect to increasing representation and research for increasing the number of people of color in medicine and research fields? Do we have specific recommendations that people can follow and be held accountable for, at the federal level and down?
I'll have to follow up on that because I need to look at what the National Academy reports are. But I can tell you that the president of the Academy, Victor Zhao, and the leadership is very, very focused on this. I mean, they looked at systemic racism and representation as one of the key strategies in which the National Academy needs to focus on.
Yeah, I wouldn't say that there's one perfect source, but there's quite a few sources out there. The American Medical Association has released some recommendations in this regard. There have been individual peer-reviewed articles that talk about this at length. I don't know that there's a one-size-fit-all solution. There's definitely many approaches that can be taken in, but certainly I'd be happy to connect with you offline to provide some resources for you, with the caveat that I hope you share them with others as well.
Absolutely. Thank you.
And our final question or comment comes from John Douglas online.
Yeah, thanks, Bob. This is a question for Carlos. Carlos, I think you mentioned in your presentation that we really haven't, when you guys looked at progress in enrolling a more diverse set of community members in various research studies, made much improvement. Is that also true in the COVID vaccine era? We've spent a lot of the last 2 days talking about what's happened during COVID, more rapid development of vaccines, bigger supply chain problems, et cetera. Did we make any progress, given the work of people like Dr. McKinney, with far greater attention being drawn to this, or is it the same old, same old?
No, I actually think we did, and I think there was an intentionality to it, and I think there was really a pressure and a pull. I can tell you, I mean, having done, for example, the Moderna study, we were one of the sites that had the highest recruitment of African Americans for percentage-wise, and it was in great part because both the sponsor and the clinical and the research team really made it a point to track this very carefully and to really incentivize sites that were doing a better job recruiting minority populations. And I would say that, again, the success, for example, from my site, and I can say the success of many sites, was because we had, we were fortunate to have had a long relationship with the community because of our HIV work. So that relationship with the African American community and that trust translated very rapidly into them participating in the vaccine studies for COVID. But if you haven't had those community partnerships and you don't have the community trust, it's going to take a long time. So I think the major lesson there is having community partnerships and community trust that go beyond just, we want you to participate in study and we'll see you later, I think makes a huge difference in the way people are willing to participate in studies and, quite frankly, then, be able to vaccine uptake and other things happen. Trust is the key to success in many of these things.
If I can add one last comment onto that, I've made those same points to researchers quite frequently, and more specifically that we need to fund these community coordinators, these people who have these trusted messengers who are already out there. And I would strongly encourage, NIH institutes, when they put out these RFPs and these FOAs, to say, that we want you to budget to have engagement with community leaders, health coordinators, whatever it is, health educators, to help bridge those gaps to your average person on the ground who may or may not know anything about this, but you may want to appropriately represent in your study for the reasons Dr. Del Rio described.
I want to thank Dr. McKinney and Dr. Del Rio for your presentations and for your interaction with our committee. I want to thank all of our presenters this morning and yesterday. We've now reached the lunch break for our committee meeting for today. We will adjourn until 1:15 Eastern Daylight Time this afternoon, at which time we'll start our federal agency updates. Thank you for joining us for our NVAC committee meeting, June 15, 16, 2022.
Produced by the U.S. Department of Health and Human Services.